A warm welcome to our Congress coverage from ASCO. ASCO is the largest cancer congress organized by the American Society of Clinical Oncology. And on behalf of patients today and Mamma Mia, I'm delighted to bring you this coverage today together with Professor Kümmel. Sherko, over to you. Would you briefly introduce yourself?
My name is Sherko Kümmel. I head a breast center in the western part of Germany in Essen, at the Essen-Mitte clinic as part of the Women's Cancer Center. I spend practically all day working on treatment concepts, especially for patients with breast cancer. At the same time, have a few other roles, as is often the case in this field. I'm one of the, let's say, scientific directors of the West German Study Group, WSG. Some of you may have heard of that before. We have this ADAPT concept, which is about sparing chemotherapy escalation across different tumor biologies. That's kind of the goal we are aiming for as an academic study group, working together with, for example, Professor Nadia Habeck from Munich and Professor Schmidt from London, or also Prof. Glus from Mönchengladbach, that is, so to speak, the WSG.
Great. Then I would say, let's get started. Together, we have selected some interesting studies that we believe are the most relevant from a patient's perspective. Why don't you go ahead and start with your presentation so we can follow up with a short discussion afterward?
Yes, let's get started. I think we've now picked out some things together where we might consider doing something different starting Monday. And that's really the key point where we currently stand, so to speak. And today's topic is everything we're going to discuss together, everything we think is important to take away from the big American Cancer Congress on early breast cancer. That means when the disease is, let's say, localized in the breast and or the regional lymph nodes, that's what we call early breast cancer in this context. So let's get started right away. This is the disclaimer, so to speak, showing my disclosures, that is my conflicts of interest, which are always presented in this kind of setting. And then one thing comes into play, and we touched on this a bit already. As I mentioned in the introduction, de-escalation, that's the term, so to speak. In medicine, people have often done a little more to be even more successful.
More is more.
And when you
The more, the better.
What? The more, the better. Yes, that's the idea. And then people said, at this and this as much as possible, that's tolerable. But eventually you reach a point where you say, well, there are many patients who might not need all of that, maybe just one or two things or one plus an antibody. That's what we call de-escalation in this context. That means we're talking about HER2 positive disease. That is where the HER2 receptor is highly expressed on the tumor cells. We all know these are the patients who receive neoadjuvant treatment. Here's a new term. What does neoadjuvant mean? It means I receive chemotherapy and antibody therapy before surgery. So I first undergo this treatment, see how the tumor responds, and then have the operation. This is the standard approach. Now let's take a look at what can be done when the treatment is given before surgery. You might say, maybe I can shorten the treatment instead of 18 to 24 weeks, perhaps 12 weeks, or use one less substance or fewer antibodies. These are all, for example, de-escalation approaches. If, for instance, the tumor cells are completely gone in the patients, can we then do something different? Those are also de-escalation strategy. It's mentioned here in the context of pathological complete response, right? That means no invasive tumor cells remain after chemotherapy before surgery when the surgical medication is examined by the pathologist. On the other hand, there's escalation if tumor cells are still present. This means that the strategy plan wasn't completely successful in eradicating all tumor cells, so to speak, in medical terms, eradicated, or however you want to put it. That's why starting systemic therapy before surgery has an advantage. It allows for patient selection and individualization, so you can decide to perhaps try another therapy and thereby prevent recurrence in more patients. And of course, we know that different medications have different side effects. So then you also consider whether to choose one or the other, something with fewer side effects compared to something that has more. All of this is usually part of the decision-making process. De-escalation concepts, that's where we're headed. For example, there's now a study on breast cancer, stages 2 to 3. So what does that actually mean? What is my stage anyway? It's a bit more than stage 1. That means, for example, a few lymph nodes are affected, or one is affected, or the lymph nodes are not affected, or the tumor is larger than 2 centimeters, or there might be more lymph node involvement. That's what stage 2 and 3 mean in this context. And they looked at that and asked, well, what's considered standard in the American study groups? What has happened there? And what does the overall picture look like? That's where the COMPASS study comes in. Of course, COMPASS is American, spelled with a C, not a K. There, they simply said all patients received 12 weeks of therapy with just one taxane. The doctors could choose whether it was paclitaxel or docetaxel. Those are the two taxanes. Most of you are familiar with them. And then both antibodies were given, that's trastuzumab and pertuzumab. For example, paclitaxel, and we often call it the dual blockade, as many know it here in our clinic, both antibodies together. The whole treatment lasts 12 weeks. Then they simply said, after that, surgery is performed. And the patients whose tumor cells were completely eradicated, who achieved a pathological complete response, were not given further treatment. The pathologist can't find anything anymore, right, Alex? That's basically the key point. They find no viable tumor cells under the microscope anymore. At most, only precursor cells, but nothing else. That would be acceptable. And then those patients didn't receive any further therapy, or so to speak, that was the purpose of the study. A current standard therapy would be TD-MON, which is an antibody drug conjugate. And in the study, it was ALRIGHT ADC antibody drug conjugate. Well, to explain briefly, it's basically the Trojan horse of medicine. Exactly. That means I take an antibody along with chemotherapy. I imagine it physically like carrying a backpack. I'm putting them into the backpack, so to speak. And then, as we learned back in biology class, maybe we did, maybe you didn't. Then the receptor looks for the docking site on the cancer cell. And then the biology teacher would always draw a lightning bolt in the cell and say something happens. But that lightning bolt doesn't actually exist, we have to say. Now we know that it wasn't exactly like that. Instead, when this happens, the cell simply takes in the complex that has docked onto it. This process is called internalization. Inside the cell, in the lysosomes here, biology taught us correctly, the cell complex is broken down. And voila, that's why I call it that a Trojan horse. The chemotherapy is released from the backpack and then destroys the cancer cell. That's a bit of a simplified explanation of the principle, if you will. Here we are. TD-MON is the antibody drug conjugate ADC of the second generation, or first, as some call it. But now we're already 1 or 2 generations ahead with the new concepts. But we'll get to that later or at another point. So that was TD-MON. The study investigated TD-MON versus standard therapy. And then there's another antibody, which is basically what's called a TKI. Now, Alex rightly asks on behalf of the patients, what exactly is a TKI? It's a tyrosine kinase inhibitor. Doesn't sound much better in English, right? Basically, it's an antibody that blocks the signal inside the cancer cell, that thing that was once imagined as a lightning bolt preventing that signal transmission. So now we've talked a lot about this in this situation. And now we have to say more than 0 patients have taken this path. We won't be able to cover the main criteria of this study today. We're all still waiting on that. Instead, today we'll focus on the question of whether TD-MON and this tucatinib, the tyrosine kinase inhibitor, are better. That will come later. Today, we can talk about how high the pathological complete remission rates were when patients were treated for only 12 weeks. In patients over 0 of them, where many also have lymph node involvement or tumors larger than 2 centimeters. So the primary endpoint always means what the study is statistically designed to measure what it's supposed to show. And if this endpoint is met, the study is considered positive. If it's not met, the study is negative regardless of any other findings. The primary endpoint here is 3-year recurrence-free survival in patients who achieved a pathological complete response. This has not yet been presented at ASCO. For now, we only have the rates of how many patients had no viable tumor cells left. So these are basically the patient breakdowns. Here, you can take a look at what the study results are like for the individual tumors. This HER2 tumor sometimes has hormone receptor positive partner, so-called triple positive casator, sometimes hormone receptor negative, and so on. And then there's also this HER2-DX test bud. We'll leave that out for today. Maybe in a few years when we meet again on screen, it will be something we routinely use or implement to decide whether a patient needs this therapy or not. That's kind of still in progress right now, so to speak. But there isn't any data on that yet. That's how we sum it up.
The findings are not yet conclusive, but that doesn't rule out the possibility that something could become evident over time.
Yes. It's now on the horizon of all possible biomarkers. It's probably the one with the highest predictive value who's most likely to achieve a pathological complete response or benefit from the treatment, so to speak. I'd say it's the most promising one. You're right. So in this situation, what does the study tell us? Today, the study gives us two key takeaways that we should keep in mind, maybe even for Monday, for our own situation. The pathological response rate is in fact quite high. Take a look here. Over 60% of the patients had tumors larger than 2 centimeters or lymph node involvement. Then 60% when the hormone receptor was not positive. We've also shown that in the WSG study group with the ADAPT study there, it was 90%, but that included more smaller tumors. If the hormone receptor is positive, only about 30%, but that doesn't mean it's less effective. Because with hormone receptor positive cases, we still have the so-called anti-hormone therapy in addition, which also contributes to survival. A very important point, about 2/3 of patients with hormone receptor negative HER2 overexpressing tumors achieve a pathological complete remission rate after 12 weeks of therapy. Nowadays, we all suspect and propose that these are probably the patients who won't need any further treatment. That will become clear in the future. What's important for Monday? The finding in this situation was that among the taxanes, you could choose either one, whether you take docetaxel every 3 weeks or paclitaxel weekly. Paclitaxel was more effective in treating the patient. So paclitaxel weekly administration is the more effective companion treatment to the dual blockade with these two antibodies. So the conclusion of the study is that patients with this specific tumor biology should basically receive neoadjuvant treatment. That's the standard, so to speak. This isn't new since ASCO, but it should always be kept in mind. That means systemic therapy is given before surgery. Paclitaxel is, let's say, significantly better in terms of effectiveness for the pathological complete remission rate, which is probably also important for survival. And nowadays, more and more patients show a significant remission after just 4 cycles, which means we might be able to operate earlier rather than waiting 16, 18, or even 24 weeks. That means we have more and more individualized treatment concepts in this context.
That is when the tumor decreases in size, and this can be detected through imaging.
Exactly. If you see remission on ultrasound, MRI, or whatever imaging is used in the situation, these cases are increasing, and we had several presentations at ASCO about this that we can't show all of now, but the evidence is building up. And I have to say the discussant, Sarah Hurwitz, is very well known in research. For HER2 positive breast cancer, she made a very clear statement and said, this is a treatment strategy worth considering starting Monday. That means...
Now, of course, I'm wondering if I switch from one drug to another and say that the new one is much more effective, that also means it comes with more side effects.
Well, it varies. Personally, I think, docetaxel, I don't really find it trivial either. So 4 times every 3 weeks also means patients often suffer from muscle symptoms, bone pain, myalgias, that is muscle pain. Then there's onycholysis, meaning fingernail problems, which occur with docetaxel, as well as watery eyes. These are specific side effects. Of course, many patients are a bit hesitant about paclitaxel because it's weekly, meaning they have to go in every week. Overall, it's not the most popular option, but regardless, if the strategy shows me that weekly use is probably the most effective therapy, then there's paclitaxel, which I consider effective. When I started my oncology career, we also tried to use docetaxel in a dose-dense schedule. That's too toxic. Administering it every 2 weeks or so wasn't manageable for the patient. So docetaxel can't be given in a dose-dense schedule. Instead, it's given weekly. Paclitaxel works and seems to have higher effectiveness. For me, based on these data, It's a clear, let's say, combination that I don't always use just for patients with tumors under 2 centimeters. That's basically my conclusion.
Great, but that's good. That just gives us more options. And you're saying we can already do that starting Monday. Then maybe I can discuss it with my care team, see if we should take another closer look at what other options might be available. So that's great.
Now, many people will probably say to you quite rightly, well, I also have carboplatin. And ASCO showed us something about that too.
All right, let's move straight on to the next study.
Exactly. And that brings us to the next point, if we take a look again shortly. HER2 positive, stage 2 and 3. We won't repeat the whole thing again here. That means tumors larger than 2 centimeters or lymph node involvement in this context. That means everything else we normally treat with paclitaxel, which is the standard either EC anthracyclines plus paclitaxel with dual blockade, or paclitaxel with carboplatin, or docetaxel with carboplatin and dual blockade. These are the standard regimens we use nowadays. What was done? A study patient group of over 700 patients, so sufficient in this context, quite pragmatically, treated once with carboplatin, once without carboplatin. Of course, as with everything, there are always some caveats. For example, the treatment was given every 3 weeks. Even the paclitaxel, which we just heard about, might not be as effective in this setting, but for better comparability, they simply did it that way. The study was conducted in the Asian region with over 700 patients in a 3-week cycle, which is not what we would do today, but you don't necessarily have to. Then there's the next study with weekly dosing or something else, and the question was asked quite pragmatically, do I really need the carboplatin? Once I used it, once I didn't again neoadjuvant, I looked at the pathological complete remission rate. In this situation, we know that in HER2 positive tumors, that is, those with overexpression pathological complete remission is a marker for good survival. What we call a surrogate marker in medicine for better survival. So here's a study again, quite classic, presented for anyone who wants to look it up. In this case, 6 cycles, 3 weeks each, so 18 weeks, a sufficiently long therapy for those who doubt that 12 weeks might be enough. So basically, here we have an adequate treatment duration. And that was basically the main question. Do patients in this situation even need carboplatin as additional chemotherapy? So now we can just look at the results and the summary. 64.1 versus 65.9 means no difference, so no significant difference. In other words, platinum showed no additional benefit in this patient group regarding the pathological complete remission rate in this situation. It's clear that if I take one less chemotherapy drug, I also have fewer side effects. That means in this case, severe side effects, grade 3 or 4, occurred in 20% versus 34% of patients. All of that makes sense. Again, back to our introduction, one form of de-escalation. First study, shorter duration. Second study, simply one drug less. So where does that leave me? Some might say that the Americans didn't use any platinum in the first study. They couldn't just ignore it. That's not true. The ones who did the work were led by Dana Farber under Eric Weiner and Sarah Tolaney. Some of you may have heard those names. They developed many of these standards. And it's important to say again that adding platinum has never really been conclusively proven to have an effect in this context. We've always done it because we thought combination therapy was more effective in this situation. So these data aren't as surprising as some might thinking, oh my God, something has to change on Monday. It means it's quite possible to skip carboplatin occasionally. Here are the PCR results, and that was independent of hormone receptor status, whether they are positive, so-called triple positive, or hormone receptor negative. In both cases, the results were completely the same, with or without carboplatin. If you look on the right side and wonder what that diagram means, it shows various factors, whether lymph nodes were involved, hormone receptor status, whether patients were younger or older, tumor size, all of that is analyzed against each other. In the middle, there's a line that's always 0. If the data points fall to the left, it favors the new approach, meaning less treatment. If the point falls to the right of the line, it means the traditional therapy was better. And as you can see, everything kind of balances out around the middle. It means no matter where you look, whether the patients were younger or older, whether the tumor was larger or smaller, whether there were more lymph nodes involved or not, or what the hormone receptor status was, carboplatin didn't stand out as being better in any patient group compared to not using carboplatin. This is basically what you might call a busy slide in American English terminology.
Just to clarify, you're referring to hormone receptor positive and negative cases, but in all of them, HER2 is positive.
Yes,
correct?
always HER2 plus.
Well, that was HER2 positive. Okay.
Carboplatin,
Yes, but
triple negative. Now, I have a feeling where you're going with this. For triple negative, carboplatin remains the standard, right?
Yes. No, but of course, it's really good to know that I might actually be able to skip it because, like you said, especially with those severe side effects, when they increase so dramatically with carboplatin, I'm honestly grateful for anything I don't have to take. And then, just like we said at the beginning, there's also the possibility of de-escalation. I can talk to my doctor about whether I really need to continue taking it or if there might be another way to go about it.
So as a backbone, the conclusion for our TheraPipe, we summarize both studies that paclitaxel with dual blockade is definitely a standard that must be maintained. Platinum doesn't seem to significantly increase effectiveness. The second point is that in a selected patient group, for example, hormone receptor negative tumors that aren't huge with not many lymph nodes involved, etc. So stage 2 as an example in this context. Today, I can imagine treating hormone receptor negative patients with just paclitaxel and dual blockade for 12 weeks, then assessing for complete remission, clinically using ultrasound and MRI and proceeding with surgery if remission is confirmed. That's basically the conclusion from these two studies in this context. Now there's a section titled Putting These Results in Context. The discussant Sarah Hurwitz said it's quite convincing what they showed from Asia in these situations. And when you compare that to other studies in the exact same situation, PCR rates, etc., that means the results from the study conducted in Asia, specifically China, are basically valid. So in other words, they basically align with the same results seen in previous studies in this setting. And of course, you prepared it really well again with your team. What does that mean? Neutropenia always means either a treatment pause, additional injections in that situation, possibly with fever, hospital stays, etc. 7% versus 16% in this case. So clearly, if I take one less chemotherapy drug, I'll have fewer side effects. That's basically a simple calculation in this context, which naturally also plays a role in the evaluation. So the takeaway in this situation, what does that mean for everyday clinical practice? Neoadjuvant combination therapy with carboplatin. In some cases, therapy can be reduced to just one taxane. I've noted in parentheses, paclitaxel.
Yes, that's great. Well, you really couldn't ask for better news. This is fantastic. And it's great to see how things are becoming more and more finely tuned, how there's real attention to detail. What's the saying? Again,
Using a cannon to shoot sparrows.
Are we just shooting at sparrows with cannons? Or can we actually aim more precisely? I really like that it's becoming increasingly individualized, the whole approach. Great, thank you so much for that. That brings us to the end of our first segment of the ASCO reporting. A big thank you to you for taking the time to go through all of this with us, for presenting and discussing the content, and I'm already looking forward to the next take. Thanks again.